A very good morning, everybody. Topic of presentation today is childhood glaucoma, its evaluation and management. So babies too can have glaucoma. The incidence varies worldwide and it depends heavily on ethnic origin. In Asia, it is 1 in 10,000 live birth. It is 1 in 20,000 live birth in Africa. And in Europe, it is 1 in 30,000 live birth. In Saudi Arabia, the incidence is high. It is 1 in 2,500 live birth. So the childhood glaucoma accounts for 5% of blindness in pediatric population, and globally more than 3 lakh children are affected. So mutations in the CYP1B1 gene have been identified and show variable expressivity and phenotypes. It is inherited in an autosomal recessive manner. In 10 to 40% of the cases, family history is reported, and the penetrance varies in the range of 40% to 100%. Clinical screening in current and future siblings is essential in cases of parental consanguinity. So childhood glaucoma is one of the most common causes of irreversible childhood blindness. It is characterized by characteristic optic disc cupping and elevated intraocular pressure. And glaucoma in infancy is associated with ocular enlargement, which is known as euphthalmos. So under the childhood glaucoma research network classification system, the childhood glaucoma is divided into primary and secondary. Primary glaucoma is most common and it is non-syndromic glaucoma in infancy with no associated ocular or systemic abnormalities. It is further subdivided into true congenital glaucoma, infantile glaucoma, and juvenile glaucoma. So juvenile glaucoma is the least common. It accounts for only 10% of the cases, and intraocular pressure rises between the age of 3 and 16 years of age. Infantile glaucoma, it becomes evident during early childhood in less than 3 years of age, and it accounts for 50% of the cases. True congenital glaucoma, the intraocular pressure is elevated during intrauterine life and is existent or becomes evident at birth. It accounts for 40% of the cases. So secondary glaucoma, it is associated with a variety of ocular and systemic syndromes. It is most common and it is associated with either cataract, aphakia, aniridia, uveitis, Sturge-Weber, or anterior segment dysgenesis. Let us focus today more on primary congenital glaucoma. So it is highly prevalent in inbred populations and consanguinity is strongly associated with the disease. Males are more commonly affected and both eyes are affected in 65 to 80% of the cases, but it is frequently asymmetrical. So if we see the normal angle of the eye, so this is the eye and it is connected to the brain with the help of optic nerve. So this is the aqueous humor which is forming from the ciliary body and it is draining outside the eye through a sieve-like structure which is known as trabecular meshwork. Suppose this trabecular meshwork is abnormal, so what will happen? The aqueous humor will not be able to drain outside the eye and it will accumulate inside the eye, leading to high intraocular pressure. And now this high intraocular pressure, it will cause damage to the optic nerve. So, and the patient will lose peripheral vision first. Central vision is affected lastly. So there are several theories regarding the pathogenesis of congenital glaucoma. It is believed that during third trimester of pregnancy, there is posterior sliding of the iris and ciliary body away from the cornea and sclera. But in cases of congenital glaucoma, there is excessive collagenous beam in the trabecular meshwork, which prevents posterior sliding of iris and ciliary body, leading to anterior iris insertion and ultimately trabecular meshwork obstruction. Several theories other are abnormal migration of neurocrest cells, faulty cleavage of mesodermal tissue, and faulty atrophy of mesodermal tissue. So what will happen because of the increased resistance to aqueous humor outflow due to trabecular meshwork obstruction? the eye pressure is elevated and it leads to loss of retinal ganglion cells and axons, further damaging the optic nerve and leading to irreversible visual field loss. So how can you tell if the baby has glaucoma? There is a classic triad of symptoms. The baby will have epiphora and along with blepharospasm and phobia. The baby will also have cloudy cornea. So how do we evaluate childhood glaucoma? Initial examination is done in the office and further examination under anesthesia is required. So office examination, we need to assess the degree of photophobia, blepharospasm and tearing. If the child is uncooperative, we can give mild sedative to the child. And generally in children as young as 3 years and in children more than 5 years, they are able to cooperate on the slit lamp. So examination under anesthesia, we assess cornea, we do refraction, intraocular pressure is measured. Slit lamp examination is done with the help of portable slit lamp, gonioscopy, ophthalmoscopy, fundus photography, and ocular biometry is also assessed. So first, we have to measure the intraocular pressure as early as after intubation, after induction. But before intubation, we need to assess the intraocular pressure because the intraocular pressure response to anesthetic agent is unpredictable. And basically, all inhaled agent, they lower intraocular pressure, sometimes rapidly and profoundly. But there are some agents which doesn't lower intraocular pressure like chloral hydrate, ketamine, and midazolam. So what we do for the serial examinations, we use the same anesthetic agent. So intraocular pressure is measured with the tonopen, and the normal intraocular pressure for infant is 10 to 20 millimeter mercury. And in a child with congenital glaucoma, it can be as high as 40 or it can be less than 23. But the symmetry of intraocular pressure is important between the two eyes. So with the help of portable slit lamp examination, we assess anterior chamber corneal examination and rule out developmental glaucoma. So during corneal assessment, we need to look for Haab striae. So now what is Haab striae? Basically what happened when the intraocular pressure is raised, because of excess collagen in the child's eye, the cornea stretches, and which leads to stretching of the Descemet's membrane, and it stretches so much that it gives up and it splits. So these Haab striae, they are curvilinear healed breaks in the Descemet's membrane, and they are typically horizontal and concentric to the limbus. It happens when the corneal diameter is more than 13 millimeter. So because of the stretching of the cornea, we need to measure the horizontal corneal diameter in a child. Normally in newborn, it is 9.5 to 10.5 millimeter, and in normal adult, it is 12 to 12.5. But prior to the age of 1 year, if this corneal diameter is more than 12 millimeter, it is highly suspicious of glaucoma. And in glaucomatous infant, the diameter can be as high as 14 millimeter. It can be more than that. So this diameter is measured with the help of a calipers. The tip of the caliper is placed on the limbus horizontally, white to white. And we measure the corneal diameter. The increasing corneal diameter is the hallmark of all forms of glaucoma in infancy and early childhood. And it is basically due to increased intraocular pressure, but it occurs before the age of 3 years. And serial corneal diameter measurement, they are useful in establishing the diagnosis and in the monitoring of progression of glaucoma up to the age of 3 years. So this is what happens if we don't treat congenital glaucoma, if we don't control the intraocular pressure. The corneal edema, which is grade 2 in this case, it becomes grade 3, grade 4, and grade 5. And ultimately, corneal scarring happens, which is irreversible. So when we do refraction in congenital glaucoma, myopia is mostly common, but its magnitude is not that high because the babies will have flat cornea and their lens thickness is also less. And the AC is deep due to relative backward positioning of the lens. So all these factors, they basically contribute to emetropization. Gonioscopy is also performed during evaluation under anesthesia. And it is crucial in making the correct diagnosis and for planning surgical treatment. We can see here that there is scalloping of the iris edges, and this can lead to anterior iris insertion and blocking the trabecular meshwork. So during ophthalmoscopy, we need to assess the cup disc ratio, and if there is asymmetry between the two eyes or a cup disc ratio of more than 0.3, then it is highly suspicious of glaucoma. But most normal infant, they exhibit no apparent cupping. So obtuse cupping in infant may regress once intraocular pressure is normalized with successful treatment in age 5 years and younger. So this is a photograph which I took pre-operatively in a child. The intraocular pressure was high, so the cornea is hazy, and we can see the cupping here is 0.6. But after surgery, when the intraocular pressure gets controlled, the cupping is 0.3. So cupping, it reverses before the age of 5 years. So optic disappearance is an important and sensitive parameter for both diagnosis and determination of progression in childhood glaucoma. So with the help of ultrasonography, we measure the axial length also of the eye, and normal axial length in infant is between 17.5 to 20 millimeter, and by the age of 1 year it increases to 22 millimeter. So let us come to differential diagnosis of glaucoma, congenital glaucoma. So it needs to be differentiated from certain conditions because congenital glaucoma, they have cloudy cornea. So it needs to be differentiated from birth trauma, rubella keratitis, mucopolysaccharidosis, mucolipidosis, congenital hereditary endothelial dystrophy. Large cornea of congenital glaucoma has to be differentiated from megalocornea, high myopia. And epiphora of congenital glaucoma, it can also be due to failed canalization of the nasolacrimal duct. And lacrimation can also be secondary to conjunctivitis, aberrant eyelashes, and entropion. So birth trauma means when there is a forceps delivery. So in that case also the Descemet's membrane break. But these breaks, they are generally vertically oriented and oblique. And there will also be periorbital skin changes due to the trauma. But the intraocular pressure will be normal and there will be no corneal enlargement. In case of congenital glaucoma, these breaks will be horizontal and concentric to the limbus. In case of rubella keratitis, the cornea is cloudy, but in congenital glaucoma, when we reduce the intraocular pressure, the cornea becomes clear. But in case of rubella keratitis, the cornea will remain cloudy, the intraocular pressure will be normal, there will be no blepharospasm, no epiphora. In case of congenital hereditary endothelial dystrophy, we will not find Haab striae, the diameter will be normal, pressure will be normal. So in mucopolysaccharidosis also, the limit of intraocular pressure will be normal and there will be no evidence of glaucomatous cupping. So large cornea of congenital glaucoma needs to be differentiated from megalocornea. In megalocornea, it is a bilateral hereditary condition and the diameter of cornea is more than 14 millimeter. But as we know that like in megalocornea, there will be no Haab striae, no intraocular pressure raised, and optic disc will be normal. And limbus will be sharply demarcated, but in congenital glaucoma, the limbus is very indistinct because the whole eye is distorted due to stretching. So this is the baby which we saw here in our OPD. This is a case of congenital nasolacrimal duct obstruction, and we differentiated it from congenital glaucoma. The baby complains of excessive tearing and mucous discharge from the eye. But as we see, the baby is very comfortable. He's not having any blepharospasm, no. Yes, epiphora was there, but no photosensitivity. And the corneal diameter is also normal and the cornea is clear. So we advise this nasolacrimal duct massage for this baby. Now, what are the causes of visual loss in primary congenital glaucoma? It can be due to Haab striae, corneal scarring, amblyopia, optic nerve damage, and refractive error. Now, how do you treat childhood glaucoma? So basically, surgery is the definitive treatment and medication plays a supplemental role. So medical therapy in congenital glaucoma is frequently needed as a temporizing intraocular pressure lowering treatment before surgery or as an adjuvant therapy after partially successful surgical procedures in childhood glaucoma. It reduces corneal edema prior to surgery for childhood glaucoma. Children, they are more vulnerable to adverse effect of medication as they may be unable to verbalize symptoms and parents may not readily recognize them. So a variety of medications are available in that in this pilocarpine we don't use normally in children because it can cause accommodative spasm and proache. Oral acetazolamide is safe. Alpha agonists are contraindicated, and prostaglandin analogs, they are third line treatment for childhood glaucoma. So beta blocker like bitoxolol is the first choice of drug in pediatric glaucoma, and it should use in concentration as lower as possible because once we instill the plasma concentration of these drugs, they are very high in kids. And brimonidine, it is alpha-2 agonist and it is contraindicated because it is highly lipophilic and it crosses the blood-brain barrier and it can lead to apnea, somnolence, and hypotension. So it has to be used very cautiously in children less than 2 years of age. Newer anti-glaucoma drugs are available like Rho kinase inhibitors, ROCK inhibitors, nitric oxide releasing agent, but these drugs, they have not been studied in children 18 years of age, below 18 years of age, so we are not using it regularly. A variety of combinations are available of anti-glaucoma medications. In this case, the Cosopt, which is a combination of timolol 0.5% and dorzolamide 2%. It is the first choice of combination drug for pediatric glaucoma. So surgical intervention is a critical component of the management of childhood glaucoma, and we need to prepare parents or caregivers for lifelong follow-up and future possible surgeries. Most children, if treated promptly with surgical intervention, can do well and they can have normal or near normal vision. So surgical decisions, we either open the natural drain, that is trabecular meshwork, by angle surgery such as goniotomy and trabeculotomy, or we can place the artificial drain like trabeculectomy or glaucoma drainage device. And with the help of cycloreduction, we reduce aqueous humor production. So primary interventions means angle surgery or goniotomy and trabeculectomy. They both are directed at the abnormal angle structure, means trabecular meshwork, and each procedure traditionally open roughly about 1/3 of the angle. So goniotomy, what we do, we directly incise the abnormal trabecular meshwork, but it requires clear cornea so that we are able to visualize the angle structures. The advantage is that it leaves the conjunctiva undisturbed for future drainage surgeries. So in this video, what I did is I introduced a 25 gauge needle into the anterior chamber, and this is the trabecular meshwork. If you see, it's a gonioscopic lens we have placed, and then I am incising the trabecular meshwork across with this needle. And so once the trabecular meshwork is incised, we expect that the aqueous humor will flow out and the intraocular pressure will get controlled. But as I said, it requires a clear cornea so that these structures I should visualize. So trabeculotomy is another form of angle surgery. In this, the advantage is even if the cornea is cloudy, we can do this surgery, and it can be done in cases when there is repeated goniotomy has been failed. But the Schelm's canal, if it is absent and if it is difficult to identify, we cannot do this surgery because in congenital glaucoma cases, babies generally have absent Schelm's canal, or it's very difficult to identify in those cases, and it opens only 1/3 of the angle. So what we do in trabeculectomy, we incise, make incision in the sclera, triangular shaped, and then the sclera flap is elevated, and then we give a radial incision, and Schelm's canal is identified with a deeper dark wet coloration and oozing of the aqueous humor. After identification, the trabeculotome is inserted into the Schelm's canal and then it is rotated through the anterior chamber angle, thus incising the roof of the Schelm's canal. The same procedure is done on the other side, and then ultimately the scleral flap is sutured and conjunctiva is replaced. A surgical video I will be showing. So Several studies have demonstrated that primary combined trabeculotomy and trabeculectomy may represent the next step in the search for best surgical treatment of congenital glaucoma. Prolonged intraocular pressure control can be achieved in patients with primary developmental glaucoma, and 42% of patients gain normal visual acuity. So this was a case presented to us at 1 week old, and the complaint was haziness of the cornea in both eyes since birth. It was a full-term normal delivery, and it was born out of non-consanguineous marriage. There was no history of antenatal maternal infection, family history was not significant, and general and systemic examination was normal. So what we advise examination under anesthesia, and we saw that the cornea diameter was 13 millimeter in right eye and 14 millimeter in left eye, and the pressure was 30 millimeter in the right eye and 40 millimeter mercury in the left eye. So a provisional diagnosis of primary congenital glaucoma was made in both eyes. We started with medical therapy, bitoxolol 0.25% eye drop in both eyes 2 times per day, and a combined trabeculotomy with trabeculectomy under guarded visual prognosis was planned. So the superior rectus spiral suture was taken, and after that the conjunctiva was dissected in this combined surgery, and then we cauterized to maintain adequate homeostasis, and then we are incising the sclera and making a triangular flap. So this flap dissection is should be very gentle in these cases because the sclera is very thin due to stretching. So the flap is elevated gently and meticulously. So after raising the scleral flap, we make a radial incision and we will try to identify Schelm's canal. We can see here that immediately there will be oozing of the aqueous, as you see here, and the color is also deep dark. So after identifying, we will introduce the trabeculotome inside the AC, and it is rotated through the anterior chamber. And then other side, the same procedure is repeated. So this is trabeculotomy we are doing. And now we will proceed with trabeculectomy. For that, we will dissect the sclera, rectangular shaped. And after dissecting the sclera, we will do iridotomy, and then we will close the flap. So this is an artificial drain we are making. And after this, the conjunctival flap will be replaced. So this was the 1-week-old child which we operated now, and after 6 months, you can see as the intraocular pressure gets controlled, the cornea is clear. So this was another baby who presented to us with the complaints of unilateral clouding of the cornea, and after evaluation of anesthesia, under anesthesia, we identified that the pressure was 40 millimeter mercury, the diameter was 14 millimeter mercury. So the diagnosis of unilateral primary congenital glaucoma was made, and we did combine trabeculotomy with trabeculectomy. So this is a 6-month-old child, and after 5 years, when the child came to us, the cornea became clear, and we can see that the child is happy. So there was a study which for surgical results of combined trabeculectomy for developmental glaucoma. In that, we concluded that primary combined trabeculectomy is safe, effective, and sufficiently predictable to be considered the first choice of surgical treatment in primary congenital glaucoma with corneal edema. So now in some refractory cases of primary congenital glaucoma and in which the angle surgery has failed, we can also place a glaucoma drainage device
The Haab glaucoma valve is the world's only glaucoma drainage device with a built-in valve to achieve immediate intraocular pressure reduction for advanced glaucoma patients. To implant the Haab glaucoma valve, a congenital incision is made, ensuring access and dissection under Tenon's capsule. Using scissors, a pocket is formed at the superior quadrant between the superior and lateral rectus muscles by blunt dissection. The plate is inserted into the pocket between the rectus muscles, and it is sutured to the sclera. The drainage tube is trimmed and cut bevel up to permit a 2 to 3 millimeter insertion of the tube into the anterior chamber between the iris and cornea. A 23-gauge needle is used to create the scleral track, starting 2 to 3 millimeters posterior to the limbus, with care taken to enter the anterior chamber parallel to the iris plane. The drainage tube is then inserted into the anterior chamber through the needle tract and inspected for proper length and position. Finally, the conjunctiva is reapproximated and sutured for closure. Once the Haab glaucoma valve is implanted, fluid drains from inside the anterior chamber through the drainage tube, regulated by the valve, then to the surrounding tissues.
So this is the surgical video which I did. And in that we can see after making the, next. So this is the surgical video which I did, and we are making a conjunctival flap. And then we will prime the, actually we should prime the glaucoma implant. And I think we cannot show this. I'm sorry. We will put that on. So after making conjunctival flap, the plate has been inserted inside the pocket of the sclera between the superior rectus and lateral rectus, and this tube is now fixed to the sclera. After fixing the tube with to the sclera with 7/0 Weichler suture, the tube has been trimmed, and now the track is made in the sclera with 23 gauge needle into the anterior chamber. So this tube is being inserted into the anterior chamber. I'm sorry for the poor quality. And now this tube is again fixed to the sclera. And this tube is covered with the scleral flap so as to avoid tube erosion in future. And after fixing this scleral flap, we will replace the conjunctiva. So we published a study that long-term surgical outcome of primary congenital glaucoma in a South Indian population. And we included children with primary congenital glaucoma who underwent trabeculotomy, trabeculectomy, or combined trabeculotomy and trabeculectomy as a primary surgery from 1997 to 2000 at a tertiary eye care center in India with a minimum of 5 years of follow-up. And then we concluded that surgical success after long-term follow-up of children with primary congenital glaucoma is low. The probability of surgical success declines over time, and children with primary congenital glaucoma require lifelong follow-up and management even after initial surgical success to prevent visual impairment and blindness. So there are recent advances. Minimally invasive surgery will play an important and increasing role in the management of congenital glaucoma. Genetic testing can help identify specific gene mutations associated with primary congenital glaucoma, enabling personalized treatment and approaches, and improved medication are being developed to effectively lower intraocular pressure in primary congenital glaucoma. So take cleaning messages, a high level of clinical suspicion is required in diagnosing the cases of congenital glaucoma. Intraocular pressure measurement and optic disappearance, they are fundamental features of the examination throughout the life of a child with glaucoma. In an infant whose eye is still vulnerable to other effects of elevated intraocular pressure, like enlarging corneal diameter, increasing axial length, and progressive myopia, also need to be taken into consideration and regularly assessed. Progressive myopia is additional evidence of glaucoma progression. Identification of Schelm's canal is the key step in congenital glaucoma surgery, and meticulous surgery results in good outcome. However, it also depends upon stage and nature of the disease. Amblyopia and refractive error should be managed aggressively. Thank you.